And finally, I told you that the intratesticular stuff tends to be malignant, the extratesticular stuff tends to be benign, but not all of it. Here is a scrotal mesothelioma, and so remember there's a lining here, there's a mesenteric lining, the tunica vaginalis, and so tumors of that lining can be mesotheliomas. And here we see focal mass in the scrotum with a hydrocele and with flow in that mass, and this was mesothelioma. Okay, so we've finished sort of our rapid discussion through the scrotum now. We've discussed testicular masses and extratesticular masses. We've discussed the acute scrotum. We've talked about the distinction between epididymitis and epididymoechitis on the one hand and between testicular torsion on the other hand. These are very important topics, and these are the two most important reasons you'll be asked to look at the scrotum: evaluation of tumor and evaluation of the acute scrotum. The last part of our lecture, we'll move on to the prostate. And we'll start with some gross anatomy of the prostate, and then we'll look in more detail. So this is a prostatectomy specimen, and what you're seeing here is this is the base of the prostate. At the base of the prostate, the seminal vesicles come in, and the vasa differentia come in. And then the prostate tapers towards its apex, and the urethra comes through the prostate. It enters at the base, when the bladder sits here at the base, it enters here, and it comes out the apex of the prostate. So the prostate is under the urinary bladder. The seminal vesicles project posteriorly and superiorly from the base of the prostate, and the prostate apex is just behind the symphysis pubis, and the urethra comes through that. Ultrasound of the prostate is preferentially done with a transrectal approach. That's the way of getting closest to the prostate. It gives you the best images of the prostate. The probe we use is anywhere from 6 to 10 megahertz. This is a transrectal image. The probe is in the rectum. This is the rectal wall here, and the perirectal fat here. And here we see the prostate sitting in front of the rectum. The probe is placed directly on the peripheral zone of the prostate. The apex of the prostate often is not as well visualized, and the anterior fibromuscular stroma, which is up here, is often obscured by a process called benign prostatic hypertrophy, or BPH, which tends to be in the middle of the prostate. So what are the objectives of doing prostate ultrasound? Well, there really are two situations where you would do prostate ultrasound. One is for benign disease, the other is for malignancy. Benign disease means you're looking for inflammatory processes in the prostate, or you're evaluating infertility. And malignancy is usually being done because someone felt the mass or there's an elevated PSA, and so you're looking at the prostate to see where is the malignancy, can I direct a biopsy into the prostate. When we do ultrasound of the prostate, we have several objectives. First off, we're going to document the size of the gland, and I'll show you how to measure the prostate and how to calculate its volume. We're going to look at the overall echo texture. We're going to look for hypoechoic areas, which can be signs either of inflammatory processes or of cancer. We're going to look for focal lesions as opposed to diffuse echotexture abnormalities. We're going to look for the seminal vesicles to make sure they're both present, that they're symmetric, that they're not obstructed. We're going to look at the vasa differentia to make sure they're present. And the evaluation of the seminal vesicles and vasa differentia and the ejaculatory ducts is particularly important when we're dealing with infertility workup. And finally, we're going to look at the periprostatic fat down here, because that fat plane is often invaded when there's a prostate cancer that's aggressive and come outside the prostate. Now in this patient, we actually see two very nice little echogenic foci here on either side of midline. This is some secretions inside the ejaculatory ducts of a patient who's being evaluated for infertility and has his ejaculatory ducts plugged up with these concretions. Okay, so prostate volume. So you're going to get two images of the prostate. This is the sagittal image on a transrectal view. Bladder's up here, apex of the prostate's down here. We see the urethra coming through the prostate. That's what the arrows show you. You're going to measure a cranial to caudal dimension. You're going to measure an anterior to posterior dimension. Those are two dimensions of the prostate. Then you're going to do the transverse image of the prostate, get the maximum transverse dimension. Take those three numbers, multiply them by pi/6, as we saw before. For doing bladder volume, we use the same formula for the prolate ellipse to get the prostate volume. The weight of the prostate in grams is very similar to the volume of the prostate in ml, because the specific gravity of the prostate is basically 1 gram per cc. The normal prostate should be less than 25 cc's or 25 grams in size. The normal prostatic echo texture shows you an echogenic outer gland. So the outer part of the gland, which is against your probe here posteriorly and comes around the prostate laterally, tends to be more echogenic, whereas the inner part of the prostate tends to be more hypoechoic, and frequently we're examining patients who have benign prostatic hyperplasia or BPH, and the inner part of their gland is often very heterogeneous. So here we have some examples of some abnormal outer glands. So here is a very hypoechoic appearance of the outer gland, a very irregular margin to the prostate. In general, if I were to teach you how to look at prostate ultrasound, I would tell you this is almost diagnostic of prostate cancer. Of course, this happens to be prostatitis in this case, but just to show you how these things can mimic each other. The hypoechoic appearance with the irregular contour is almost always associated with prostate cancer. This is a hypoechoic appearance throughout the entire posterior aspect of the prostate, and this turns out to be an infiltrating prostate cancer. Notice that in this case, the peripheral zone tends to be less echogenic or darker as compared to the inner gland, which is more echogenic. And that's because of the abnormal echotexture in the outer gland. When we image the prostate, we usually image in transverse and sagittal planes. The transverse plane is very nice for comparing one side to the other. So here, this is a normal echotexture on the right side. This is an abnormal hypoechoic echotexture on the left side. The difference in echotexture is your tip-off here that this is a cancer. And this is a cancer. And if you look carefully, there's a slight irregularity of the contour here as well, invasion through the perirectal fat from the prostate into the rectum. But the transverse image allows you to make that comparison of side to side. It allows you to look at the neurovascular bundle here and here to check them for symmetry. You can see the seminal vesicles and check those for symmetry. And we often use the transverse imaging plane as the plane preferred for biopsy because you can actually tell how far out you are laterally. And it turns out that prostate biopsies should probably be done in a very lateral orientation. Here's the sagittal image. We always use both a transverse and a sagittal image. We see hypoechoic mass in the transverse image. We'll go to the sagittal image to confirm that it's really present. The sagittal image is also better for evaluating the base and the apex of the prostate because you can see when you're at the base and where the apex ends. The ejaculatory ducts come from the SV into the urethra, and they can be imaged in a sagittal view. Seminal vesicles are often seen more throughout their length on a sagittal image. And sagittal views are very commonly, especially out in the community, sagittal images are probably the most common method used to guide prostate biopsy. So here's back a transverse image again. Here we see the neurovascular bundles, two of the big venous structures in the neurovascular bundle. The structures are not so well seen on this side because they're shadowed out. But this nice normal echogenic peripheral zone, slightly heterogeneous inner gland related to BPH, and neurovascular bundle. Now the prostatic urethra can sometimes be very difficult to image in our patients because they often have BPH and it obscures the urethra. The example I'm showing you here is a patient who has a Foley catheter. The Foley makes the urethra extremely obvious. It also tends to straighten out the urethra a little bit. The urethra tends to come down to the level of the viru. The virum montanum is where the ejaculatory ducts insert into the prostatic urethra, and there's what we call a pre-prostatic urethra, which runs from the bladder neck down to the virum montanum, and then the post-prostatic urethra comes down to the apex of the prostate, and there's usually a 35-degree turn between those two portions of the urethra. In this case, you can actually see the urethra very well because it's distended by the Foley catheter. This patient does not have a Foley catheter, but you can still see the urethra. It's marked by some corporal amylacia or some bright echogenic markers here, which are probably within periurethral glands. This urethra is surrounded by a hypoechoic structure here at the top of the prostate. So remember, the urethra comes down from the neck of the bladder here. That's the base of the prostate toward the virum montanum, and then from the viru toward the apex. Now, that part of the urethra here, the preprostatic urethra, from the neck of the bladder down to the virum montanum, is surrounded by muscle. That's the internal sphincter. And sometimes that muscle can look hypoechoic. It's very important to know that anatomy because you do not want to mistake this for a mass around the urethra. If you were to mistake this for a mass around the urethra, you would probably end up biopsying this area and perhaps end up biopsying the urethra, which is in general not a recommended procedure because it results in a lot of hematuria. Remember, the internal sphincter comes off the bladder, it's continuous with the bladder, and it ends at the level of the virum montanum.